is the common situation that we face with in the office when you have leukoplakia, erythroplakia on the vocal cord. But again, with the standard endoscopy, you have not adjunct information to presume the histology, because these lesions look very similar, but unfortunately are completely different. This is a keratosis, this is a mild dysplasia, and this is carcinoma in situ. So you need something more to understand the biological behavior of this lesion. And NBI help you because you have to focalize on the vascularity and not only on the macroscopic appearance of the lesion. Leukoplakia, erythroplakia are clinical definition, but don't help you to understand what there is behind the leukoplakia on the erythroplakia. So the concept is to perform, in this case, a resection of the entire lesion in the clear margin to have the possibility in only one procedure to perform diagnosis of the entire lesion and to have the possibility to precisely evaluate the margin of the resection. So you don't need to perform a staging microlaryngoscopy. You can do both things in the same procedure. So again, with the NBI, you can discern among different atypical vascular patterns, because as you've seen before, we have abnormality in the direction of the vessel. You have abnormality in the morphology of the vessel. So if you focus on the vascular network, you can distinguish between inflammation, between dysplasia, probably also carcinoma, because you have a minimal differentiation between superficial atypical vascularity and deeper atypical pattern. Very important to discover invisible or not visible with a white light satellite foci. This is important, for instance, when you have a field cancerization of the larynx. Or, of course, during the operation, in the intraoperative setting, identify the mucosal extension of the lesion. And this is very important to tailoring your resection in each patient. This is just an academic classification about the different type of atypical vascular pattern that you can find in the larynx. This well-demarcated area, you see in white light just erythroplasia, with NBI very well-demarcated area with a dark spot inside. This means that they are the apex of the loops, of the intracapillary loops. They change the direction from the deeper layer to the superficial layer. So they change from longitudinal to the perpendicular, and you can appreciate the apex of the loops. Again, you can see the many branches. Again, this means that the intrapapillary loops change the direction. And this is very common in the recurrence papillomatosis. You cannot appreciate the dark spot because the loops are wider in the viral diseases. In this lesion, you can see three different patterns. The dilated vessel that changes the direction, the dark spot in the surrounding tissue, and the loops inside the lesion. So you have a different pattern. It's interesting also this picture, where in the white light you focus on the anterior part of the vocal cord, but with NBI you can define a line between the healthy tissue and the lesion. You can appreciate the dark spot also in the posterior part of the vocal cord. You can appreciate the hypertrophic vessel coming and stop just before the line, because it changed the direction in this situation. This is an example of erythroplakia, untreated erythroplakia. It was suspicion in the office, so we put the patient in the OR. You can appreciate the difference between the two vocal cords. With 70-degree telescope, you can scope the subglottis, the anterior commissure very well. The 70-degree is very useful. And of course, when you can see in the healthy vocal cord the longitudinal direction, the physiological direction of the vessel, here the direction is completely abnormal. Of course, you can combine this information in the office with video stroboscopy. The new tower gives you the possibility to have stroboscopy information also. This is the set that I suggest to have in your OR, the 0-degree telescope, the 70 that is very useful to evaluate the ventricle, even the bottom of the ventricle, and also 120-degree telescope to see the subglottis from the below to the supraglottis. This is an example of a patient in the OR with the 0-degree telescope. You can appreciate this lesion of the right vocal cord. With NBI, you can confirm the suspicion, so we can appreciate many dark spots. With the 70-degree, you can better define the anterior commissure, and you can see also some dark spot on the left vocal cord here. With NBI, you can better appreciate this atypical dark spot. And again, with the 70-degree telescope, you can appreciate also a satellite foci here in the bottom of the ventricle. It's very difficult to see, even with the microscope. It's impossible to see this. But with the 120-degree from the subglottis, you can see that the two lesions come together, join together. So this lesion was upstage after this visualization from T1 to T1B, because there is a bilateral involvement of the vocal cord. One thing that is very important to keep in mind is that every time you have some bleeding or caused by the intubation of some endoscopic maneuver, you can use the NBI anymore, because the light is completely absorbed by the bleeding, because the 425 nanometers is the peak of the absorption of the hemoglobin, so the physical principle of the NBI. So you have to be very careful when the anesthesiology intubate the patient. I prefer intubate the patient myself to avoid any bleeding during the intubation. Also, when the residents start to perform the endoscopy, I always suggest to be very carefully, don't touch the lesion. You have to go very close to the lesion, but don't touch the lesion, because if you have bleeding, you have to stop your examination. Another maneuver very useful in the workup is the hydrodissection in the superficial layer of the lamina propria. When you have a complete ballooning of the lesion, you presume that the lesion is confined to the epithelium. By contrast, is part of the lesion remain attached to the vocal ligament, probably we face with some microinvasive carcinoma. So this is a very easy procedure, very economic procedure, but it's very useful to get you some adjunct information about the depth of the invasion of the lesion. More or less like the video stroboscopy in preoperative setting. So we perform this kind of algorithm in case of erythroleucoplakia or potentially malignant lesion, when we found that normal mucosal wave of endoscopy, normal hydro dissection means a complete ballooning of the lesion, and NBI negative, no suspicious atypical vascular pattern, we usually perform excisional biopsy in terms of subepithelial chordectomy. That means we spare completely the vocal ligament. It's the less invasive chordectomy that you can perform. It's type 1 according to the ELS classification. By contrast, when we have some abnormal mucosal wave, we have no hydrodissection, and we can detect some atypical vascular pattern, we perform a subligamental chordectomy, as I showed you before. So we remove completely the vocal ligament and also the superficial part, a very thin superficial part of the muscle, to be sure about the oncological radicality, because most of the invasive carcinoma are limited to the vocal ligament without infiltration of the vocal muscle. Of course, when you have some doubts, it's better to perform a deeper resection to be sure to have a clean margin in the histology report. So these are the three types, or the first three types of chordectomy. In untreated cases, we perform type 1 or type 2 according to the algorithm. We perform a type 3 when the patient comes with a biopsy already done. Because if you have some fibrosis or scar tissue due to the biopsy, of course, you miss the information coming from the video stroboscopy of the hydrodissection. So you are obliged to perform a deeper resection. This is the reason because it's better to perform a very accurate workup instead of the random biopsies. That doesn't make sense, because if you just make a punch biopsy and you have the histology of carcinoma or a severe dysplasia, you are obliged to make a re-resection deeper than in type 1 and 2. So this is our routine use of excisional biopsy. I give you some example. This is the type 1, the vocal ligament completely spare. The type 2 subligamental in the specimen include the mucosa and the vocal ligament. You spare completely the vocal muscle, and the functional result is comparable, because even if you remove the vocal ligament, the closure is complete, and the mucosal wave of the opposite vocal cord still works. So the voice is comparable even to the normal subject. And when you have to perform a type 3 transmuscular chordectomy, of course, you have a little bit incompetence and worse voice, because you have to remove an immediate portion of the vocal muscle. For this reason, I suggest to perform these two chordectomy in case of limited lesion without involving anterior commissure. But to be sure to have a clean margin, you have to follow very precisely all steps of the workup that I showed you before. So, in summary, for lesion limited to the epithelium, intraepithelium lesion confined by the mesomembrane, when you have a normal mucosal wave, hydrodissection, NBI negative, you can perform subepithelial chordectomy, sparing the vocal ligament and the muscle. This is the case of leukoplakia, erythroplakia. The palpation also is very important with this banded suction tube. We perform hydrodissection with the bender angle. just to reach the superficial layer of the lamina propria. You can see a complete ballooning. The NBI was negative. In this case, you can perform subepithelial chordectomy. In this case, you can use cold instrumentation also, it doesn't matter, because you are in the avascular layer. The laser makes a difference when you perform a subligamental or transmuscular chordectomy. I use the Boucher dissector. You can see the vocal ligament here. I use the laser just to define, to underline the limits of the lesion. You can see very well, is the phonosurgical technique, the same as you use for benign lesion. With the wet cottonoid, you find the plane, the superficial layer, in order to remove all the mucosa lining the vocal cord and sparing the vocal ligament. You can see here the vocal ligament, all the mucosa, any attachment here. So in this case, you have a specimen that includes all the mucosa, so the pathology is happy because you send a very good specimen for evaluation of the margin, the resection, and to make a precise diagnosis of the entire leukoplakia. This is a less invasive chordectomy that you can perform. I go a little faster. It's very important to well-orient the specimen, to maybe to mark the specimen with some ink, and to have a very close collaboration with the pathology. You have to invite the pathology in OR to decide with him what is the best way to send the specimen. By contrast, in case of microinvasive carcinoma transgressing the basal membrane, you are obliged to remove all the ligament, even a very thin portion of the muscle, just to give to the pathology the possibility to evaluate eventually the infiltration of the muscle. This is the case of subligamental chordectomy. You can see some dark spot and branching vessel. Again, I perform a ventriculectomy just to have a better visualization of the lateral extension of the lesion. This I perform a routine ventriculectomy because you optimize the visualization of the vocal cord. You make, with the same concept, the resection of the mucosa of the vocal cord in the deeper layer, in the subligamental layer. You can cut the mucosa through the anterior commissure, extending subglottically, without transgressing the midline to avoid any synechia. So you can see the muscle completely spared. And finally, the transmuscular chordectomy, just in case in patient already biopsied. In this case, you are obliged to perform a deeper resection because you miss all information coming from the routine workup. So the same concept, but again, you go a little deeper. So you remove also a part, a medial portion of the vocal muscle. Again, I performed ventriculectomy to better control the lateral extension of the lesion. This is very useful also during the follow-up, because if you remove the ventricle, the false cord, you can appreciate eventually some recurrence in the bottom of the ventricle. You can see a good margin, yeah? And you can obtain this just if you have a very good visualization of the ventricle. And of course, I have to remove some muscle And it's important also the interaction of the laser with the tissue. If you have not carbonization, usually you are cutting the healthy tissue. It makes a difference when you cut healthy tissue of tumor. This is the concept introduced by Steiner from Göttingen in the piecemeal chordectomy for bulky tumor. The different interaction between laser and tumor or laser and healthy tissue. You have always to rotate the specimen in order to have under control also the inferior margin of the lesion, as I make now, just to have a precise control of the inferior margin, just to get a good margin of the inferior part of the muscle. And you reach the conoelasticus here. You can see the conoelasticus here. And of course, you have to control the anterior commissure. It's better to rotate all the time the lesion to have under control all the margin of the resection. So the margin of the resection has a unique situation in laryngeal surgery. Of course, we are talking about ultra narrow resection, as you have seen, 2-3 millimeters. So we define, or I mean in the literature, is define negative margin when the tumor is, when you have more than 1 millimeter from the macroscopic appearance of the tumor, or better, from the NBI margin. Closer when it is inferior, a positive if you have a dysplasia or cancer where you cut, where you perform the resection. It is important to distinguish between a negative margin, single superficial positive margin, multiple superficial positive margin, and deep positive margin. When you have a multiple superficial positive margin or deep positive margin, it means that your resection is incomplete. You performed a mistake. So this is some example of, this is a case of recurrence respiratory papillomatosis. Again, some example, how useful is the NBI in detection of the satellite foci. For instance, in the white light, you cannot appreciate this area, and also the posterior extension are not visible, even if you are in high definition white light in microlaryngoscopy with a rigid endoscopy. You have the gold standard of the standard endoscopy in this case, but with NBI you have adjunct information compared to this imaging. And this is very important when you treat papillomatosis, otherwise you miss some foci in the different part of the larynx. This is another case of a papillomatosis. You can see here the lesion in white light, but you miss completely this information and this information. So again, you have adjunct information about the superficial spreading of the lesion. This is a case of squamous cell carcinoma. You can see in white light, and now you become more familiar, and you start to see the vascularization even in the white light, and you see some atypical morphology of the vessel in the surrounding tissue, even inside the tissue. But of course, with NBI, is more clear, is more visible, is more precise. Again, the macroscopic margins change completely. So if you have to plane the resection, you have to follow this margin and not this margin. So you have make a wider resection. And of course, as Professor Farah show you later, probably from this margin to the healthy margin, you have some biological or molecular changes. and I show you later a very elegant paper written by Professor Farah, where the number of molecular changes, changes, abnormality, is much higher, close to the tumor compared to the resection margin. And this is another case, again, with gold standard endoscopy, white light. You cannot not appreciate as precisely the extension, the mucosa extension of the lesion. This is the reason because I perform always routinely the ventriculectomy, just to have under control with the 70-degree telescope the lateral extension of the lesion. Okay, you can see here the flora seems to be normal, but with NBI you can appreciate some dark spot even in the lateral part of the ventricle, the vocal cord. So we try to objective evaluate this adjunctive value of the NBI in this paper. We evaluate a cohort of 96 patients, and we have a gain of 36% in 35 patients in terms of upstaging intraoperative from, for instance, T1A to T1B. And in 9 patients, again intraoperative, we have a better evaluation of the tumor margin. So in 35 patients, we change our surgical plane based on the information coming from the NBI evaluation. This is another paper written by the Genoa group. This was my residence a few years ago. And we tried to compare a group of patients treated by our group in the era previous NBI and in the era after, with NBI routinely used. In the group of selected patients of T1 glottic cancer without previous biopsy with very adequate exposure without involvement of the anterior commissure. And the superficial extension was, of course, evaluated switching from high definition white light to high definition NBI. And what we find that we reduced dramatically, significantly, the number of positive margin for 24% to 3.6% after the routine use of NBI. This means that we reduce the number of patients that need, for instance, re-resection or adjunctive therapy after the first treatment. This is another paper written recently from our group, where we compare two groups of patients, T and T1 patient and a small group of T2 patient, and we observe that using the NBI, we reduce again significantly, or we increase significantly the number of negative margin between the two groups. This also was found in the group of T2 and T1, of course, in all patients. So the number of negative increase and the close margin decrease. This reflects in the survival, improving the recurrence-free survival in patients treated when we use routinely the NBI regarding the negative and the multiple superficial layer. So what is our policy when we have multiple superficial positive margin, deep positive margin? Routinely, we perform a second TLM. In case of, again, a superficial margin, we shift to open neck procedure or adjuvant radiotherapy. In case of closed margin, negative margin, or single superficial margin, you follow the patient very closely. Okay, this is a sum up, but regarding only the margin. Okay, thank you for your attention.